My name is Jamie Latos. I'm one of the rheumatology staff here at WVU on the Morgantown campus. I'm happy to be here, and today's topic that I was sort of asked or tasked to cover today is inflammatory myopathies, which may go by a couple different names. Oftentimes, we just sort of generically refer to them as myositis, or sometimes they're termed idiopathic inflammatory myopathies, but hopefully we'll hit some of the highlights today for those folks out in the community. I have no disclosures, I should say, kind of pertaining to this talk. And then the brief objectives. So the first thing that we're going to do is kind of do an overview of these idiopathic inflammatory myopathies, just kind of referencing a lot of the different categories or subclasses that do exist, because there are several that kind of fall under this general nomenclature of a myositis or idiopathic inflammatory myopathy. As you kind of see as we get into the PowerPoint, the main focus of today's talk is going to be going over two main subtypes, which are dermatomyositis and polymyositis. So we'll talk about different things like epidemiology, different diagnostic criteria, the variable different manifestations that may come about with these types of myopathies. And then we'll go through kind of the evaluation of these patients, as well as a discussion about initial management and overall prognosis in general. So I start with this slide first, just because essentially all rheumatologic conditions are considered systemic, and so we're very familiar with some of the most prominent ones, like rheumatoid arthritis or psoriatic arthritis or psoriasis or things along those lines. But they all can extend outside of their margins of whatever their primary manifestation may be. So even this talk is kind of focused on inflammatory myopathies, and we would think, okay, that's the main manifestation. They really can come with a whole slew of different manifestations as well, or different organ systems that can all be affected by the same universal or systemic process. So we focus a lot on skeletal muscle involvement in these cases, but it is important to kind of not forget that there can be GI involvement, pulmonary involvement, vascular involvement with some types, cardiac involvement, of course, skin involvement, or even musculoskeletal involvement. So when we're evaluating these patients, we really need to kind of think of them as a whole, and keep our eyes peeled for other organ systems that may be affected outside of their muscle. The classification criteria that we still kind of operate off of were sort of formulated way back in 1975. So these are the Bohan and Peter criteria. And the first kind of three are the ones that this presentation is going to focus on mostly. These are the ones that we tend to encounter most often in the clinic. So that's adult polymyositis, adult dermatomyositis, and then either dermato or polymyositis that may be associated with an underlying malignancy, because those are not uncommon. As you can see on the list there's a variety of others. Certainly these things can affect children as well. So there's juvenile forms of myositis. We may have overlapping myositis with another associated connective tissue disease. So this can be a lupus with a myositis, a scleroderma with a myositis, an RA, or a Sjogren's that has sort of a coinciding inflammatory myopathy at the same time. There are cases of inclusion body myositis that we may encounter along with our neurology colleagues. And then there are some pretty unique kind of phenotypic presentations, such as things like anti-synthetase syndrome or these immune-mediating necrotizing myopathies, which you may be familiar with in terms of the statin-related myopathy that sort of triggers that autoimmune pathology. So again, there are many different presentations, many different kind of characteristics to these types, but for the purposes of this talk, we're sort of honing in primarily on polymyositis and dermatomyositis specifically. So these are not the most common conditions that walk into rheumatology clinic compared to things like RA, for instance, or psoriasis, but we do see them not uncommonly. So incidence can be estimated anywhere between 0.1 to 2 cases per 100,000 person years, which kind of translates to a prevalence of anywhere between 2 and 30 per 100,000 people. There are some differences between dermato and polymyositis in terms of what patients are more at risk or more likely to develop these conditions. Dermatomyositis is really kind of does not pick a particular age. There's sort of in general two different peaks of when we expect or may see it happen. So there's a peak kind of during childhood that goes through adolescence, and then a peak later kind of in middle-aged part of life. So that can hit children and adults. Polymyositis On the other hand, unfortunately, is very rare to happen in children or in the adolescent patient group, but more kind of in that middle-aged patient population. In general, with rheumatic or autoimmune diseases, I mean, there tends to be sort of a predominance for these to affect females as opposed to males, and this is one situation that kind of follows the same suit. So, with inflammatory myopathies, particularly dermato or poly, females are rated to be about 2 to 3 times more likely than a male to develop these. If we kind of rewind to younger age patients, the child or juvenile dermatomyositis is pretty evenly shared between men and female patients. There may be some genetic associations with some of these cases as well. These would be more kind of things done in research rather than kind of in clinical work, but they can share some certain HLA-B types that kind of may predispose those patients to be at greater risk. When we talk about overlapping myositis conditions, so this would be something where you have a myositis with another connective tissue disease, the rates of these going up in females then becomes really drastically more significant than what we see in males. Males may have a slightly higher predominance of developing the inclusion body myositis. Um, and then there's sort of, different parts of the world or different parts of even a continent, may vary. And one of the proposed sorts of things is that, you can kind of see this north to south gradient, in different parts of the world. And so that people have postulated like what role does the UV radiation have in sort of modulating the immune system? Like why would patients closer to the equator have higher risk or rates of developing these things versus patients that live in more northern climates or parts of the continents? The next few slides are just kind of hitting on major diagnostic criteria. So when we think about inflammatory myopathies, these are the big things that kind of automatically come to our mind. And the first off is proximal motor weakness. And weakness is really the key when we're talking about inflammatory muscle conditions. And we look for that weakness to be objective. So a lot of patients may subjectively say that they feel weak, that they have no energy, that they're starting to kind of see themselves not be able to keep up or do what they needed to do. But when we're evaluating these patients, we're doing muscle strength evaluation, looking to see if they have objective weakness that seems to localize to their shoulder or pelvic girdles, or sometimes the neck flexor muscles. The onset of this is typically gradual, so it may occur over the course of several weeks to several months, where patients are, sort of noting, okay, something's not right. I'm not feeling myself. I'm having a harder time getting myself out of bed in the morning. But it should again be clustered mostly around kind of their upper arms, upper back, the shoulder girdle muscles, and then kind of the upper thighs, buttock, hip areas. If patients are endorsing weakness or they're noted to have weakness in anything like their ocular or facial muscles, that's going to swing the pendulum away from one of our typical inflammatory myopathies and maybe something more to a neurologic phenomenon or whatnot. And so that would not be very characteristic of a poly or dermatomyositis. The other thing to note in these patients is they generally, pain is not their presenting symptom. So, as you all know, and everyone knows, there's a lot of patients out there that endorse myalgia and may have the sense of being weak. But pain is not a predominant feature in inflammatory myopathies. There are some exceptions to that rule, but again, in our typical cases of dermato or polymyositis, these patients by far present with proximal weakness than they do coming in complaining of pain. Outside of their sort of typical skeletal muscles, they can have other striated muscle involvement. So that can be things like pharyngeal muscles with leads to dysphonia. The upper esophagus can be affected, and that can lead to things like dysphagia or aspiration risk. And if you have involvement of those things in conjunction with sort of your proximal muscle girdle symptoms, then generally you're thought to have more severe disease presentation. The next kind of big variable or diagnostic criteria that we look for in these cases are elevated muscle enzymes in the serum, with the CK kind of being the most touted or most often checked. And so this is oftentimes going to be elevated at some point in time in patients who truly have an inflammatory myopathy. Now, there's no set cutoff that the CK needs to reach for it to be considered clinically significant. There can be patients that have dermato or polymyositis where the CK might be just borderline elevated or maybe at 300. And then there can also be patients where it's at 3,000, 10,000, 15,000. So there's definitely a spectrum in terms of the severity of CK elevation that can happen. But, keep in mind, generally, these inflammatory myopathies are not going to be the thing that gives you the CK reading of 25, 30, 40,000. In those cases, kind of think more rhabdomyolysis or toxic or infectious or something like that. They're generally not going to peak quite that high. Other labs that we look at would be things like aldolase, which can certainly fluctuate with the degree of muscle involvement. Elevated liver enzymes in the setting of an elevated CK will oftentimes be elevated, and they don't always imply that there's liver damage being done. It's just sort of a coincidental finding of elevated LFTs that may actually improve as the CK trends downward, particularly if the patient had no underlying liver dysfunction leading up to this kind of presentation. One thing that can be checked to kind of help differentiate whether that's more of a related to CK elevation causing the LFT rise is to check a GGT. GGT is less likely to be affected by CK values, and so that can maybe offer some reassurance as to, how's the patient's liver function actually doing. If the GGT is normal, then you may be able to chalk up the AST and ALT elevations to the elevated CK. And then oftentimes, if the patient has it done, they will be expected to have some abnormal findings, especially if the symptoms have been ongoing for weeks or months. If it's just a matter of maybe a week or two, then sometimes the EMG won't pick up on it, or it might not be as specific. But if symptoms have been present for some time, then an EMG can really be helpful. The couple things that are listed under there, those are kind of characteristic or typical findings that we would expect to see in patients with inflammatory myopathies. But the thing to note is that the EMG, while abnormal, the nerve conduction study portion of that test really should be normal in cases of dermatomyositis or polymyositis. We don't expect to see neuropathic changes in terms of larger fiber nerves, but more irritability or dysfunction within the muscle fibers themselves. Then other things. So this is specifically for dermatomyositis. The first part of that term implies that there's some cutaneous manifestations, which there oftentimes should be. Now, the rash itself can vary in terms of location and also sometimes in the appearance, but in patients that undergo biopsy, what we would expect to see is sort of a description by the pathologist of this interface dermatitis. So, where the inflammatory infiltrate is occurring in the different layers of the dermis is kind of key to a lot of different connective tissue diseases, and so it can mirror the biopsy of something like lupus or a Sjogren's rash, or it can be consistent with dermatomyositis. In the left column, these are all just descriptive kind of terms for the different rashes that have been, noted in dermatomyositis, and we'll have some pictures on subsequent slides of examples of some of these things, but most of you have probably heard of things like heliotrope rash or Gotrin's papules, the shawl sign that hits the upper back. A couple that I didn't have pictures of, but a holster sign would be sort of this erythematous rash that kind of goes down the lateral hip. Mechanic's hands being sort of dry, roughed, cracked, or splitting skin that primarily localizes over like the radial aspect of the first, second, and third digits in the hands. And then I do have an example of some nail fold abnormalities on a subsequent slide. One thing to always keep in mind, try not to be tricked by a rash that looks erythematous and may happen to be over the knuckles, because that doesn't always mean it's a slam dunk for dermatomyositis. Certainly, there are different infections that can cause mimickers or a mimicking appearing rash. There's simple things like contact dermatitis that may behave similarly. Some medications may cause similar appearing rashes. So, rashes can be a big clue for us, but we certainly need to associate it with other signs, symptoms, and evidence to suggest that, hey, our rash is truly related to this underlying, inflammatory myopathy or connective tissue disease in general, as they can be sort of tricked or misleading from a variety of other factors as well. Here's just a few examples of the heliotrope rash. So this is oftentimes described as sort of a lilac-colored erythematous kind of purplish rash that has the tendency to want to hit the eyelids or the kind of periorbital area. Sometimes it can be subtle, and so these are obviously pretty significant representations of what it can look like. But when you're examining patients, if dermatomyositis is on your list and you don't see any obvious sign, or maybe it's a patient that happens to be wearing some eyeshadow or eye makeup, it's a good idea to have them remove that or have them close their eyes, because sometimes you may only have a very limited kind of violaceous rash that's sort of tucked behind the upper eyelids and might be missed, if you don't have the patient kind of close their eyes and take a pretty thorough look. These are some examples of Gotrin's papules. So again, kind of these erythematous, almost plaque-like cracked areas that have a tendency to form over extensor surfaces, especially over the hands. They will likely or most often localize over the knuckles, so over the MCPs, PIPs, and DIPs. There's another slide coming up, which kind of will show you like a mirror image, which again can kind of be a mirror, a mimicker. But differentiating where the rash is localized to can give you your clues as to what condition is actually leading to the rash. Gotrin sign is, very similar appearing rash, but generally larger in area and covering other extensor surfaces, so elbows and knees, but similar in appearance. The shawl sign, not sure how many people wear shawls anymore, but this is kind of a rash that occurs in the area that would sort of drape over the upper back, the shoulders, and may extend down onto the anterior chest or down the proximal portion of the arms. And then, I alluded to earlier, if you focus on pictures A and B, A is a very kind of more typical presentation of dermatomyositis or the Gotrin's papules, where the erythema is localized right over the knuckles themselves on the extensor surfaces. Photo B is kind of an opposite image. So you see clearing over the knuckles, but definite involvement of the interphalangeal spaces. And that's a rash characteristic of lupus. So yeah, keep that kind of in mind if you do have a patient that presents with some systemic symptoms and a rash that may be on the hands. Where is it happening can clue you in as to what underlying condition or disorder you may be looking at. The other thing is, I mentioned on one of the very first slides, kind of talking about multi-system involvement, where vascular system can sometimes be a component or an area that is affected. Oftentimes these patients may endorse a history of Raynaud's phenomenon or on, gross exam of their nail fold capillaries or with use of magnification with a dermatoscope or ophthalmoscope. You can actually detect some of these microvascular abnormalities. It's one of the few places you can look at blood vessels without needing a biopsy. And so if you have a patient who has had relatively recent onset of Raynaud's phenomenon and maybe they're kind of middle age, so that's not the most thing to kind of just develop later in life, and they have abnormal nail fold capillaries and some of these other systemic symptoms. This is just another feature to kind of raise the bar, raise the suspicion for an underlying connective tissue disease process. Nail fold capillaries, they should be bilateral if abnormal. If you have one finger that has one maybe slightly thickened loop, that certainly can just be an incidental finding. But this would be a good representation of just with plain eye sight, seeing some of these dilated loops. Typically, I describe these to patients, they should look like bobby pins. So a nice thin symmetrical loop, and they should be sort of lined up like soldiers in a row. So you can get loops that are engorged or dilated, loops that are, instead of being a nice bobby pin shaped loop, they are more tortuous or irregular. You may see areas of hemorrhage that extend out into the cuticle or actually grow up into the nail bed, or areas where there's dropout, where it seems like the vasculature is affected to the point where there is no longer or the presence of these capillary loops. So checking nail fold exams can be, again, just kind of one feature of these connective tissue diseases that maybe is a clue that helps us lean towards secondary Raynaud's of an associated autoimmune condition or potentially primary Raynaud's, just of the general population. And we talk a lot about okay, muscles and rashes, but I should note there is one subset of dermatomyositis that presents with rashes without muscle involvement. And so this one can be, potentially tricky to diagnose because you're lacking one of the other big features of dermatomyositis, which is weakness or notable CK elevations. This actually can be up to maybe about a third of cases of dermatomyositis, maybe what they call clinically amyopathic or CADM. Now, just because they may start off in this manner doesn't mean they're going to continue to follow in this manner. So it's estimated that maybe about 50% of these patients who start off without obvious or detectable muscle involvement may develop that over time. So that's where the terminology of provisional CADM or confirmed CADM is based on kind of how long you have followed the patient and how long they have stayed without detectable muscle involvement. If it's been about 6 months, it's kind of provisional. If it's been 2 years and they've still not developed muscle, weakness or CK elevations, then you can feel more comfortable kind of labeling them as a confirmed case of clinically amyopathic dermatomyositis. Now, this doesn't always mean that this is a better form to get. We talk about kind of other organ systems being affected. So while muscles may not be affected, these patients can have associations with an underlying malignancy, and they can also be at risk of developing the rapidly progressive interstitial lung disease, regardless of whether their muscles are affected or not. And so this is one of the things that we tend not to get too kind of comfortable or calm with, thinking that we're in the clear just because it's a rash, because we do know some patients will develop more things, and some patients actually some of the more severe manifestations, especially if they have a certain antibody profile, something like the MDA5 antibody, which we'll kind of go through in more detail here in just a little bit. And then because these are systemic diseases, not just attacking skin and muscle, they can have a whole slew of different manifestations. Highly inflammatory things generally make people feel just unwell. And so oftentimes patients will report that they've been more fatigued. They may have low-grade fever or chills or sweats, unintentional weight loss. Generally, inflammatory myopathies are not the things that are going to cause the spiking 103, 104 fevers, but lower grade fevers, 100.4, somewhere in that kind of range. A lot of patients may endorse arthralgia, so they may have some kind of joint pain. There are subsets of people, particularly in the antisynthetase syndrome category, that truly have an underlying inflammatory arthritis. We mentioned, the potential for interstitial lung disease, especially in those antisynthetase groups, but anybody who may have, muscle involvement can be at risk again for things like aspiration pneumonia or just ventilatory muscle weakness, which again would be one of the more severe kind of presentations. There can be GI involvement, essentially from, mouth all the way down through the GI tract. So sphincters can be involved. There can be incontinence issues. And fortunately, rarely and generally not in the adult population, but dermatomyositis kind of being housed under the vasculitis/vasculopathy kind of category of things. There's been reports of intestinal perforations more, and so the juvenile dermatomyositis cases, but pretty rarely. There can be cardiac involvement, and then there can be different forms of cutaneous involvement. So we talked about rashes, but more on the vascular side. Some patients may present with a true like leukocytoclastic vasculitis. They may have skin ulcerations. They may have livedo, so sort of this kind of lace-like pattern of a sort of ruddy or violaceous rash that tends to affect the lower extremities, or they may have Raynaud's phenomenon as a component of their condition. Now, before we get into kind of workup, it's also kind of important to keep in mind, things that might seemingly want to present as an autoimmune disease can be mimicked by a variety of other things too. So, we're talking about inflammatory myopathies today, but you'll see some other rheumatic diseases listed under the inflammatory column there, things like RA, Sjogren's, vasculitis that may also cause weakness or rashes and so forth. And so other non-typical immune-mediated muscle conditions can also cause muscle involvement. There can be endocrine disorders, things like thyroid dysfunction can contribute to myopathy. Electrolyte disorders certainly can. There can be different metabolic or inherited myopathies that can present similarly. And then a big one to kind of keep in mind are drugs or toxins. And so this can be anything from, chemical exposures to illicit drug use, to chronic alcohol use, anything under that kind of umbrella can contribute, including some prescription drugs. And just to point out a few, we use colchicine quite frequently to treat, things gout and pseudogout. Patients that have chronic colchicine exposure may be at risk of developing a myopathy. And then another very commonly used drug category, which are the statins, can cause a couple different scenarios of myopathy. There's the most common where the patients develop some myalgias or maybe a very mild CK elevation, which is resolved, self-limited and resolved upon stopping the drug. And then there's the more aggressive variant of that where it actually triggers more of an immune-mediated myopathy that targets muscle fibers, causes muscle fiber death and necrosis, and can lead people to have significant weakness. And that version requires more than just stopping the statin. That version requires, relatively aggressive immunosuppression, and we treat it much like we would for these types of inflammatory myopathies like dermato and polymyositis. Different viral infections, bacterial infections, parasitic infections can also appear similarly, and then various different causes of rhabdo. So if somebody was in major trauma, seizures, different toxic exposures, they may result in a pretty significant CK bump as well, and be managed more conservatively with fluids and hydration and monitoring without the need for immunosuppression or steroids. So the diagnostic evaluation for these conditions, rheumatologists in general, especially our new patients, who tend to spend a good bit of time taking histories or trying to, because we're really trying to tease out through all organ systems, what clues can we find to kind of put the pieces of the puzzle together. The big things, of course, we're looking for are signs of proximal weakness, maybe some systemic symptoms, reviewing labs that they may have had done leading up to that point. But a lot of your information can come from good history taking and clinical exam. Again, not just asking, does the patient feel that they feel weak, but are they actually weak on exam? Or, is their muscle strength 3 or 4 out of 5, and primarily affecting proximal musculature rather than distal. Imaging can be very helpful, and so we, a good bit of the time in the evaluation of myositis, whether it be for a new patient or an established patient that we're concerned might be flaring, MRI can be helpful at sort of elucidating, is there an inflammatory myopathy present on imaging? But also for our new patients, it can help identify a spot that might be high yield in terms of going after for a biopsy. So if you have an MRI of the humerus or an MRI of the thigh that shows the surgeon exactly what muscles are affected, then when they go in and do their biopsy, you're inherently going to have a much higher yield as opposed to doing a random biopsy of just sort of some proximal muscle that may not be affected, because it doesn't need to be every muscle consistently or universally affected. You may have one and not another, or one area that's more so affected than another. And so you really want to, if you're going to put somebody through a biopsy, you want to have the best chance of being able to determine or get the answers that you need. When we order these, we ask the radiology team to do it with this stir imaging protocol, which helps to kind of just do fat suppression. So it helps the radiologist when they're looking at it kind of determine what is inflammation versus fat versus edema or fluid, because depending on the T1 versus T2, fluid can appear differently, edema or inflammation can appear differently. And so their protocols can help kind of tease through that as to what might be edema or fluid or anasarca versus actual inflammation in the muscle. These are just few representations of things that we would, maybe expect to see. And so when you see bright white on T2, that kind of denotes inflammation. And so you can imagine if you're asking a surgeon to do a biopsy and they have this image to look at and they know exactly where they're going to get their best yield, it's better for the patient overall in terms of being able to, get the one biopsy and hopefully get the answer done. And then this was briefly mentioned on one of the other slides, but EMGs certainly can be helpful, but there's a couple of things about them that we need to keep in mind. While they do have good sensitivity, they're not a very specific test for an inflammatory myopathy. There are those kind of characteristic findings that we would look for, but they're not always reported in the same way, or not every patient may have all, the sort of triad or 4 findings all together at the same time. So, but in general, things that we're looking for, things like irritable myopathy findings, increased insertional activity, and then this kind of term that we look for, it's on board exams for rheumatologists, which is what's referred to as MUAPs, these low amplitude, short duration motor unit action potentials. That's kind of a key word for us to look for that might signify an inflammatory myopathy. And again, in cases of polymyositis and dermatomyositis, the nerve conduction study portion of the test is generally unremarkable. In things like inclusion body myositis, you may notice some abnormalities there, but really when we ask or ordering these studies, we're looking mainly for the EMG component of the test. Muscle biopsy can be definitive. Not always required though. And so the pearl about this is if you have a patient who has a very classic presentation of dermatomyositis, proximal weakness, elevated muscle enzymes, and a characteristic rash, you generally don't need to go muscle biopsying these patients because the likelihood that it's going to add a yield to it is not as likely. Now, caveat to that is if you are concerned about maybe something overlapping or the patient's not responding to treatment in the manner that you would typically expect, or if they happen to have maybe some distal muscle involvement as well. Those would be things that would kind of say, hey, maybe this isn't our typical dermato. Maybe we're kind of off target with our treatment. Maybe we need to get a biopsy to kind of know for sure. But in general, if it's a more clear-cut case of dermatomyositis with typical rashes and the typical muscle involvement, biopsy is not always needed. The other thing when kind of considering a biopsy is if the patient has had an EMG, we have to be careful not to request a biopsy that's been done on that side. So if we do ask for EMGs, generally we're going to ask for them to be done unilaterally, maybe an upper and a lower extremity, but on the same side. That way we can preserve the contralateral side for the biopsy if it needs to be done. And we'd also try to avoid doing biopsies in patients who've had a history of rhabdo within the past few months, just because that can create a lot of artifact on the muscle biopsy, and then it's very hard to interpret, what you might be dealing with. I don't want to go too kind of down the road of talking about histology and whatnot, but these two conditions, even though they can present similarly in terms of their muscle involvement, are different. They're very different in a few ways. One is sort of what is triggering the process. So polymyositis is thought to be more of a T cell mediated process, whereas dermatomyositis is more complement mediated in the complement activation system. And then also differences in terms of where you might expect to see your inflammatory infiltrate. And so in polymyositis, the way I've always remembered this is I think poly of many muscle fibers. And so you would expect to see inflammatory cells infiltrating around individual muscle fibers themselves. These fibers are generally not going to be necrotic, and that's why these patients generally don't have pain as a presenting feature. But the muscle fibers can atrophy over time or shrink as they've been affected by inflammation. In polymyositis, we don't expect to see the vasculature affected. Contrast that with dermatomyositis. This is more of a peripheral kind of condition, and so most of the inflammation is going to be kind of clustered or surrounding the perifascicular areas, not kind of weaving its way in between individual muscle fibers. And we also expect to see, or would typically see, inflammatory infiltrate kind of surrounding vessels that are running through the muscle body as well. And so that's where I alluded to earlier. Dermatomyositis is a bit different because it's kind of housed or considered to maybe be under the vasculitis or vasculopathy kind of category of things because of where we see inflammation when we look on slides. There's a couple cartoon representations of what that previous slide is describing. So again, polymyositis, I think many muscle fibers are affected, and so inflammation just weaves its way through and goes around and attacks individual muscle fibers. On the picture on the right, on the very bottom, you can kind of see that the muscle fibers more towards the bottom left of the screen are generally normal in size, but as you kind of move to the right, closer to the fascias, where you see a lot of atrophy of those muscle fibers and a clustering of your inflammatory infiltrate. And then that circular thing that you see on the bottom of the bottom right photo for dermatomyositis is a vessel wall that has clustering of inflammatory cells kind of circulating around it. And here's a few real life representations of just the very same thing. So individual muscle fibers being affected, causing atrophy versus more peripheral involvement with kind of localized muscle atrophy. Both can be equally as disabling and both can cause equally as significant of a CK bump, but they are different generally in terms of their pathogenesis, in terms of the cellular inflammation and where it's affecting the muscle. The other thing that can be helpful for us, and this is not a requirement for a diagnosis of an inflammatory myopathy, but there are several different myositis-associated antibodies that can be checked. And if you have the suspicion or maybe have come across these ordered by rheumatology before, these are referred to as myositis-associated antibodies, and there is an orderable test within Epic if you type in myositis panel this comes up and it gets many of these different things. These are also helpful for diagnosis, but like I mentioned, not required. But when I tend to look at them more helpful is it can offer some suggestion or clues as to where that patient fits best phenotypically. Is it dermato? Is it poly? Do we need to be looking for an associated lung, kind of picture? Is this one associated with an overlap syndrome? Is this associated with a statin? So it kind of gives you clues as to like, okay, how's this patient maybe going to present? What do I need to be looking for? But then also maybe offer some insight in terms of general prognosis looking forward, because some may be associated with poorer versus better prognoses. So we won't touch base on every single one, but some of the highlights of these specific myositis antibodies. So the first kind of syndrome is anti-synthetase syndrome, and that was on one of the very first slides talking about sort of the Peter and Bohan criteria. So this is an inflammatory myopathy, but it comes with other things. And so those other things are generally going to be an interstitial lung disease, an inflammatory arthritis, and then some sort of skin manifestations, particularly those mechanic hands, those dry, rough, cracking hands that you may see on exam. There are a couple other antibodies that you can see listed there that also can be associated with anti-synthetase syndrome. And again, where those kind of come in are maybe different phenotypic presentations of the same thing. So PL7 and PL12 antibodies tend to have associations with more aggressive interstitial lung disease, but actually less of a myositis burden. And JO1 in general, or anti-synthetase syndrome in general, those antibodies are less likely to be associated with a malignancy. SRP is another one of the antibodies that can actually be associated with a very more acute onset of an aggressive muscle attack. These patients may actually develop muscle fiber necrosis, so they tend to have a lot more pain associated with their weakness. This antibody profile also has a higher association with potential for cardiac involvement, as well as poorer overall response to steroids and a much lower survival rate than what most of our patients would have. So again, if you're evaluating somebody who has a pretty severe clinical presentation and you happen to see an SRP antibody positive, this just offers further information to maybe how aggressive should we be with this patient up front, or, hey, this might be kind of the trajectory that we're looking for in terms of a more aggressive, more refractory, higher morbidity associated condition. MI2 is another antibody that's classically associated with dermatomyositis, or more often associated with dermatomyositis. So these patients get the very classic kind of dermato skin manifestations. Has the overall probably best prognosis with a more than 90% 5-year survival rate. So when we're kind of teaching our fellows and residents about these different antibodies and which is associated with what, I kind of think me too. Like if I had to have an antibody associated with this, I would want the me too antibody because it generally has the best overall prognosis. And then there's the 155 or 140, which is also known as a TIF1 gamma. The reason we pay attention or care about this one so much, particularly in our adult patients, is this one carries a significantly higher association with an underlying malignancy. And so that might be a malignancy that has already been discovered, but the thing we always worry about when we see patients with any inflammatory myopathy, but particularly the TIF1 gamma antibody, is where is that cancer potentially hiding? And so we have to sort of do evaluations and screenings and verify that that those aspects have been looked into. The MDA5 antibody, I referenced that one earlier. Again, that one can be seen in the amyopathic patients with dermatomyositis. These patients can also have aggressive skin ulcerations, kind of the classic patient that fortunately we don't encounter very often, but that you kind of read about is a patient who's MDA5 antibody positive, who has myositis, necrotic skin ulcerations or digital ulcerations, and a rapidly progressive interstitial lung disease, that patient is intubated in the ICU. And sadly, this version or this phenotype of myositis is not as likely to respond to even some of the most aggressive immunosuppressants that are out there. So they generally have a much poorer prognosis overall. And then I won't go into the rest of them there because I know there's a whole lot of these antibodies and they all can be seen to different things. But again, when we check them, there is a reason. It's not because it's a requirement for the diagnosis, but it does offer further insight into other organ systems that we need to be looking for, the potential for an associated malignancy, and then some insight as to, the potential prognosis for these patients overall with treatment. One or two slides kind of talking about malignancy, because again, the TIF1 gamma is an antibody that sets off those alarm bells for us. But any patient in general, particularly an older adult patient who's just now being diagnosed with an inflammatory myopathy, we always have malignancy on our radar. And so it's estimated that you can find a cancer in more than half of the patients that are diagnosed with these conditions if they're over the age of 65. And it may be present at the onset of their myositis presentation, sometime within the first year, and that's going to be in about two-thirds of patients. But it may precede the diagnosis of their myositis or occur anytime within the first 3 years, if it truly is a myositis that has a malignancy association. It's not to say that every patient with myositis has an underlying cancer. That's certainly not the case, but we worry most about it in our particular antibody profiled patients and the older patients that are diagnosed. And it can be any underlying malignancy. It can be those that are common, those that are not as common, depending on your background or where you're from or ethnicity. It may vary into like nasopharyngeal cancers. Those are higher in the Taiwanese population. Comparing dermatomyositis and polymyositis, there's a definite higher association in dermato for underlying malignancy than what there is in polymyositis, but it's still increased in polymyositis. So always be on the lookout for a potential malignancy if we're encountering or seeing these patients. And then again, looking at the antibody profiles, some are more sadly associated with malignancy, whereas others share less of an association, and so they may offer some reassurance or at least a little bit of breathing room to kind of not be as worried about hunting for a cancer if you're Jo1 or MI2 positive, for instance. We would generally consider screening all of our patients at the onset of their diagnosis, or at least inquiring or ensuring that they're up to date with age-appropriate cancer screenings. We're by no means ordering PET scans on all of our patients, just kind of hunting, head to toe. But if we have a, adult patient, middle-aged or older, female, asking when was the last mammogram, when was the last pap smear, do they still have ovaries intact, or have they undergone a complete hysterectomy? Colonoscopies universally for men and women. If you're a male, checking on things like prostate, colonoscopy, asking about prior, smoke exposure, tobacco smoke, or whether it was, patient was a smoker themselves or they had secondhand exposure. It is generally thought of, we would at least kind of ask about those organ-specific cancer screenings and consider getting a screening chest, abdomen, pelvis CT at the time of diagnosis. Just, again, kind of doing as much as possible thorough investigation to make sure we're not missing an underlying myositis. And we always come back to this, especially in the patients that we see who are really refractory to treatment. There's always kind of a little seed in our mind that's wondering, like, why are they not responding? Is it because this is more of like a perineoplastic kind of presentation where until that underlying cancer is sort of discovered or dealt with, their myopathy or myositis is really going to be hard to control. So one more slide, just kind of an algorithmic approach again to kind of screening for these patients. We're not ordering CT scans annually. If their initial ones are clean, and they're up to date on other age-appropriate cancer screening, then some of those more invasive tests or more expensive tests like CT scans can be reserved kind of for more of like a symptomatic basis or depending on if your concern rises down the line. Now, the last couple minutes, the last few slides are just talking about management. And so when we think about kind of clinical presentations of these patients or any rheumatic disease, they all fall along a spectrum. And so some patients are very mildly involved, other patients severely involved, more detrimental, sometimes even lethal because of their condition. So we don't approach every single patient with the exact same treatment regimen for the most part. We really try to base it off of what's their presentation, how aggressive is it, where are they affected, what organ systems are involved. So patients that generally have things like severe weakness, maybe they're bedbound, they're non-ambulatory, they have respiratory muscle weakness, if they have interstitial lung disease at diagnosis, if they have one of those higher risk or higher, or poorer prognostic antibody profiles, or an associated malignancy, those are generally going to be considered poorer prognostic features. Regardless of whether they have those or not, steroids are typically first line management. And so it kind of depends on oral versus IV prednisone based on their clinical picture as well as where are we seeing them. If they have a CK that's 800 and they walked into the clinic and they're not having dysphagia or respiratory compromise, generally these are patients that are managed outpatient with oral prednisone. On the other hand, if we're consulted in the hospital or somebody comes through the ER because they've been deteriorating and declining over the last few months at home and they're non-ambulatory, they are choking on food, those are the patients that we're going to pivot to IV steroids. And oftentimes what we refer to as pulse dose steroids, they're like very high doses of solumedrol up front and then transitioning over to an enteral form of steroid after a short time period. While corticosteroids are used up front in nearly all cases, they are not considered an effective treatment in and of themselves. And so most patients, more than 50%, are going to fail if you treat with steroids alone and try to taper them down or taper them off. So in most cases, we need to have some other version of an immune suppressing medicine on board to assist with disease control, as well as getting rid of the steroids in time. As we all know, steroids come with a lot of additional baggage in terms of side effects and risk factors, including the doses that we would use. Anything above 20 milligrams of prednisone is considered immunosuppressing and pretty broadly immunosuppressing. And so patients are at great risk of infection, even if they're just being started on the prednisone and haven't had anything else added to it at that point. There are a handful of other immunosuppressives that we would commonly pivot to. Methotrexate and azathioprine are two of those most common ones. Mycophenolate, which is the MMF, or leflunomide can be used. Cyclophosphamide, which is probably our most powerful immunosuppressant and the one that comes maybe with the most risk of side effects, can be used, but is obviously going to be referred for that sort of big gun therapy in patients who are either the ICU patient who is rapidly declining or the patient who's been refractory to everything else. You can consider less significant DMARD. So let's say it's one of the amyopathic dermatomyositis patients who predominantly presents with a skin rash, but doesn't have muscle involvement. It doesn't have any underlying interstitial lung disease or another organ system. So if skin is your primary target, sometimes if it's mild enough, we may get away with use of hydroxychloroquine, which is Plaquenil, topical steroids, and exposure to sun. Sun tends to be a provoking factor for a lot of these connective tissue disease-associated rashes, including dermatomyositis. Just to highlight a couple other agents on this next slide. So IVIG would probably be, especially in the acute phase, in the very affected patient, so the patient that's in the hospital, IVIG can be added there along with high-dose steroids for its very fast-acting benefit at helping to reduce muscle inflammation. Now, it's maybe not the most logistical or feasible long-term maintenance medication, although some patients do take it chronically. But typically it's used up front to sort of put the fire out or help put the fire out, and then maybe used for a period of time there in conjunction with a prednisone taper to kind of bridge somebody over to some other version of a steroid-sparing agent. And then we would gradually try to aim to taper off of IVIG. But it is a very effective anti-inflammatory. It's very expensive, and so it does need to obviously go through the insurance pipelines and make sure that that's doable. Different biologics have been looked at. So rituximab is used in some of these cases of refractory myositis. We have started to kind of explore and use in some cases JAK inhibitors. So things like Xeljanz that we use in other scenarios like RA and psoriasis, they're now kind of crossing over into this aspect of autoimmune disease. Physical therapy is key for these patients up front and throughout their course, actually. So I have patients who do sort of revolving courses of physical therapy. Those are the ones who have been significantly impacted, but they do need to maintain muscle strength. If they are on steroids and bedbound and not doing PT, they're very unlikely to make a clinical improvement. And then keeping in mind the meds that we use, steroids included in that, are very risky from an immune suppressing standpoint. So Prednisone comes again with its own baggage. So anybody that's on higher doses of prednisone, 20 milligrams or more for the foreseeable future, should be on some version of PCP or PJP prophylaxis, either with Bactrim or atovaquone. And then keeping in mind, steroids are very unfriendly to bone health, particularly in the early phase of starting them. So if you have an older female or male who might be frail or already have a history of osteoporosis or fracture, consideration for the need for bone health medications as well. This is just a pictorial kind of representation of those couple of slides, kind of working through the algorithm, which is steroids, steroids, steroids up front for everyone, essentially. PO versus IV, depending on kind of the clinical significance, followed by one of our first line DMARD agents. If we're not seeing progress, we consider adding things to it, like IVIG or another DMARD, and then progress down to the biologics kind of as third line therapy. And then one of the last slides just talking about prognosis. So generally in these idiopathic cases, so those that aren't associated with malignancy or one of those high or poor prognostic antibody profiles, it's estimated about 85% at the 5-year mark. So fairly good. In particular, the MI2 again kind of carries the best prognosis overall, contrasted by the worst prognosis seen in things like SRP or potentially MDA5 antibody positivity. Things that kind of come along with poorer prognosis overall is obviously if this is an older individual when they're diagnosed, if they have an ILD, especially an advanced one, if they have cardiac involvement, dysphagia at presentation, or actually if they are of a non-Caucasian race as well, may have a poorer prognosis. And again, if there is an underlying malignancy, merely on the front of the underlying malignancy itself, but also the potential trigger for that for the immune system, oftentimes that kind of implies a poorer prognosis for these patients as well. And the last slide, which is a summary slide, just some kind of highlights from the presentation. So again, although there are many different types of inflammatory myopathies, this focused on primarily polymyositis and dermatomyositis as two of the most common that we would encounter in clinic or in the hospital. And again, generally, these are going to present with this insidious onset of proximal muscle weakness, which should, in most cases, by out far weigh their pain that they report. So I know a lot of people in their clinics see a lot of people who have muscle pain, and sometimes it's diffuse and they feel weak, but really try to pay attention to, are they objectively weak, and what do they endorse more? Is it weakness or pain? And that can kind of guide you down the road of maybe an inflammatory muscle problem versus something that's non-inflammatory, let's say rotator cuff insufficiency or fibromyalgia or one of those conditions that, a lot of times patients feel weak or might be weak, but whether they're weak with pain or weak without pain can kind of be a clue. CKs, again, can be very variable. So this might be just a few hundred above the cutoff, or it can be several thousand, peaking over 15,000. But it really should not be the thing that gives you the 30,000, 50,000 CK. That shifts more towards toxic infection or rhabdomyolysis. And then the diagnosis is formed through kind of a mixture of different things. It's history, physical exam, but then objective features like skin rashes, the different myositis antibodies, which aren't required but can be helpful, MRI findings, EMG findings, and then ultimately tissue biopsy if it is pursued. And then based off tissue biopsy, the characteristic features of individual muscle fibers being sort of attacked or affected in polymyositis versus more of kind of that peripheral muscle bundle, perifascicular involvement in dermatomyositis, and also some clustering around the vasculature in dermatomyositis as well. And the reason we care about those antibodies, again, it kind of gives us an idea what we're looking at with these patients. Are you merely muscle involvement, muscle with skin, muscle with lungs, and what your prognosis might look like, as a result of that? And then again, the initial treatment for all of these patients, steroids up front, depending on the degree of their clinical, involvement. If they're ambulatory but affected with an elevated CK, oftentimes it's oral steroids, outpatient management. If they are declining, significantly or unable to function at home, certainly a reason why patients should be in the hospital and getting more aggressive therapy up front. So that is it for me. If anybody has any questions, I'm happy to take those now or after the fact.